Well, now we'll be talking to you regarding complication of acute myocardial infarction. So in the complication of MI, first is bradyarrhythmias or heart block. Son is bradycardia, that means the heart rate is below 60 per minute. Well, and it is very common in inferior wall MI. And in this case, if the patient has problems, especially low BP, then we need to treat this patient. We give injection atropine or we can give injection isopranoline. But still, despite giving this medication, if the pulse still remain in the bradycardia range, then in that case, we may have to go for temporary pacing. It needs to be done. Now, after that, we talk about heart block. First degree heart block, what is that? Normal PR interval is between 0.12 to 0.20 second. If the PR interval is more than 0.20 second, then we call it to be first degree heart block. First degree heart block is a benign condition. Normally we don't need to treat specifically, but we need to keep a watch on this because this can progress to higher degree of the heart block. Then we talk about 2A block, so-called Ventricular phenomena. What is this? In this we get, this is the PR interval. In the next beat we get longer PR interval. Then we get a longer PR till. So there is progressive increase in PR interval in the subsequent beat till a P is followed by P only and there is drop of QRS. This is so-called Ventricular phenomena or 2A block, and is also known as Mobitz type 1 block. At times you get confused, Mobitz type 1 block, first degree heart block, they are all two different entities. This point should be noted very carefully. It's again a benign condition. Benign condition means we don't need to treat aggressively this condition, but we definitely have to keep a watch on this because it can again progress to higher degree of the heart block. Then we have 2B block, so-called Mobitz type 2 block. What is this? Like P, QRS, 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 QRS. So we are getting a fixed number of P wave followed by QRS. This is Mobitz type 2 block, also called 2B block. This is a dangerous condition and this need to be paced because it can go into complete heart block any moment. And after that we have a complete heart block, so-called third degree heart block, and it's the one thing which can produce syncope also. This can produce low BP also. This definitely needs temporary pacing at the beginning. Bundle branch block, right bundle branch block, left bundle branch block, bi or trifascicular block. RBB is a benign condition, nothing worry about it. In LBB we have to be very watchful about this condition, but bi and trifascicular block, they need to be paced. After that we talk about tachyarrhythmias. Tachyarrhythmias are very common in anterior wall MI, and in fact hypoxia, hypokalemia, hyperkalemia, hypoxia, acidosis, they are the predisposing condition for this. That means whenever we are facing a problem of tachyarrhythmias, we must make sure that there is no electrolyte imbalance and there is no acid-base disturbance which can predispose to various types of arrhythmias as well as blocks also. And one more thing, regular blood complex tachyarrhythmia after MI is always due to all ventricular tachycardia. Now, we got one patient who is having ventricular tachycardia. If patient is hemodynamically stable, one more point you must note it down. In ventricular tachycardia, patient may have normal BP or patient may have low BP. If he has normal BP, what we typically call as hemodynamically stable, and if the BP is low, we say patient is hemodynamically compromised. So if he is stable, in early VT, that is between patient come within 24 hours, we can give infusion of lidocaine or amiodarone by infusion. But if patient come after 24 hours or the patient has late onset ventricular tachycardia, then we can give amiodarone infusion, and we also start oral therapy with amiodarone or sotalol. Then patient is hemodynamically compromised. Then we have, that means patient has VT with low BP. Then in that case, we have to give DC shock. And of course, after that, we start infusion also. But first, we give DC shock. We don't wait, because this can go into ventricular fibrillation at any moment, and patient may die. Atrial fibrillation or atrial flutter. Again, if hemodynamically compromised, give DC cardioversion. But if patient is stable, then we can give digoxin or beta blocker also. Or we can give amiodarone or sotalol also. The various drugs that we can use to treat this condition. Now, as I told you, bradycardia is very common after inferior wall MI, and tachyarrhythmias are more common after anterior wall MI. Now, the third complication is a pump failure or left ventricle failure. In fact, it is the most dangerous complication. And in a case of acute MI, the outcome of the case depends on presence or absence of evidence of pump failure, and this we classify as Phillips classification. So we have class 1 to class 4. Let's see what are the things. In class 1, patient has acute MI, and there is no evidence, no signs of any heart failure. So we call as class 1, and in this case, mortality is 5 to 10%. Class 2, we have evidence of heart failure in the form of crepitation at lung basis, third sound, or tachyarrhythmia. Mortality becomes 20 to 25%. Then, class 3, patient has signs of severe heart failure, pulmonary edema, systolic BP above 90 millimeter mercury. Point to be noted, patient has pulmonary edema, but systolic BP is above 90. Mortality 50 to 60%. Cardiogenic shock, that means systolic BP is below 90. Of course, patient has pulmonary edema, severe heart failure. The only difference between 3 and 4 is systolic BP below 90. This is cardiogenic shock. Mortality is 80 to 90%. But before I proceed further, I have given you mortality figures like this. This vary from place to place, depending on how good is the medical facility in that particular place where the patient is admitted. But by and large, giving the idea of this percentage is to make you understand that it is the pump failure, severity of pump failure, which tell you the outcome, and how good is the outcome depend on pump failure. Class 1 mortality 5 to 10%, class 4 80 to 90% is the mortality. Now, regarding cardiogenic shock, I was talking to you, systolic BP is below 90 millimeter of mercury. And cardiac index is below 1.8 liter per minute per meter square, and pulmonary capillary wedge pressure is above 18 millimeter of mercury. And that indicates LA pressure is very high in this condition. And how to treat a case of cardiogenic shock? We use vasopressors in the form of dopamine, dobutamine, or norepinephrine. Norepinephrine is given in the range of 0.5 to 30 microgram per minute by IV infusion. Dopamine is given 10 to 20 microgram per kg per minute by again IV infusion. In this particular dose, patient, he has alpha-nergic action. In this, and alpha-nergic action will lead to what? Vasoconstriction. Vasoconstriction in turn will lead to what? Increase in the peripheral resistance, which in return will lead to increase in blood pressure. So this is how we are going to treat by medication about cardiogenic shock. But in addition to that, we also use intra-aortic balloon pump, and we also use PTCA. In fact, PTCA is percutaneous transthoracic coronary angioplasty. And in fact, this is the best way to treat a case of cardiogenic shock. But this facility is not available everywhere. But infusion of vasopressor is available in all the setups. Now, what about intra-aortic balloon pump? What is this? It contracts and relaxes in synchronization with the heartbeat. The purpose is it pushes the blood forward. It acts as a bridge for surgery for valve replacement or transplant, or it also used in patients who are having cardiogenic shock. Okay, well, we got one patient on cardiogenic shock where we are planning to do PTCA, but it takes some time to reach the cardiac center, or by the time we arrange PTCA, so it acts as a bridge for the patient. And of course, in other complication, I'll be discussing soon, we'll be using this IABP till we are able to transport the patient to operation theater. So let us see, what is this? So in intra-aortic balloon pump, during diastole, this pump get inflated, and during systole, it get deflated. So it pushes the blood forward. And now one more thing, basic concept, coronary filling occur. 80% coronary filling occurs in diastole. So that's why it's very essential that we are maintaining the pressure in diastole, and so that in systole, when the heart and heart beat, it also tend to push the blood forward. Okay. Now, right ventricular infarction. Proximal right coronary artery is the one which supply the right ventricle. Okay. And right ventricle also supply the inferior wall also. And whenever we have right ventricular infarction, patient may have normal or low BP. Is very, very important point. Low BP or patient may have normal BP. JVP is raised. But what is so special about it? Clear lung fields. That means you auscultate the chest, you do not get no crepitation, no crackles. So patient having a raised JP with clear lung field, and Kussmaul sign is positive. What is Kussmaul sign? Let's learn the basic concept. Normally, JVP falls on inspiration. But there are few conditions where JVP rises on inspiration, and this is known as positive Kussmaul sign. Now, what are the causes of positive Kussmaul sign? One is right ventricular infarction, other is constrictive pericarditis, and third is restrictive cardiomyopathy. There are three important causes which we are clinically more commonly encounter. So here we get positive Kussmaul sign. And how we really diagnose this condition? ST elevation in RV4. What is RV4? Let's learn the basic concept. Right-sided V4. Right-sided V4. So let's see how we really do the normal recording of ECG. Sternum, we keep V1 lead here, V2, of course, in the second intercostal space, then V3, V4, V5, V6. This we normally do when we want to see the ST elevated MI. But when we have to see for right-sided infarction, then we do this placing of electrode in a reverse way. This become RV1, this position. This become RV2, RV3, RV4, RV5, V6. Same way the way keep, but we just change the direction. And we write R, that means the right-sided leads are there. Okay, so in this case, RV4 is the specific sign to look for the right ventricular infarction. Of course, at times they write RV4 to V6 also. But if you are asked a single lead, then this is the best answer. Well, let me show you the ECG. Look, I've got two ECG recorded in two parts. Of course, same patient. A, you are getting inferior wall MI. You are getting ST segment elevation in L2, L3, AVF. Okay. Now, now same patient, we do the right-sided recording. In the right-sided recording, now we can see that in RV4, we are getting ST segment elevation. Of course, it is going up to V8, V9. V8, V9 is, we know V6 is up to mid. As we proceed further, as we go down more and more laterally, that is V5, after V6, V7, V8 also. What I want to convey the message is, it's the right-sided lead which will pick up the right ventricular infarction. That's why classically, in any case of inferior wall MI, which you can see some changes in V2, V3, L2, L3, AVF, you must try to record the right-sided lead also to rule out right ventricular infarction. Okay, how to manage the right ventricular infarction? Do the Swan-Ganz catheter studies, and what is going to see is going to see the right-sided pressures are there, and in the what we get classically when we do catheterization of the right-sided of the heart, they reveal hemodynamic pattern resembling like constrictive pericarditis. What we get? Steep right atrial wide descent, an early diastolic dip, and plateau in RV waveform. This is a classical point that we see in case of right ventricular infarction. In fact, such patients are preload dependent. Now, what do you mean by preload dependent? Because they have a profound hypotension because of inadequate right ventricular preload. That's why to increase the BP in such cases we use IV saline, because they are preload dependent. Okay, and we in these patients, all those drugs which reduce preload like diuretics, like nitrate, they should not be used. They are contraindicated in this condition. Now, pericarditis, this is one complication which can occur from day 1 to from 3 months, anytime it can occur. Classically, patient come with pain chest, and we get in the ECG, you get saddle-shaped ST segment elevation, and we always do echocardiography to rule out any effusion. Pericardial effusion should be ruled out. Rather, if effusion occurs, the pericardial pain disappears. What is special thing about this pain? This pain is more in supine position, and pain get reduced when patient leans forward. This is a classical of pericardial pain chest. Of course, on auscultation you get pericardial rub can be there, or we can auscultate. And if you are getting rub, this confirmed pericarditis. As I told you, echo will be done, and treatment is simple NSAID, non-steroidal anti-inflammatory drug is used. So here is the ECG. You can see this saddle-shaped ST segment elevation. It indicates pericarditis. Saddle shape, concavity is there. This is seen in pericarditis. But we get also ST segment elevation. This is convexity upward. This is what we see in acute MI. And this is acute pericarditis. Deep vein thrombosis and pulmonary embolism is a big problem because patients keep on lying on the bed for a long time. That's why it's essential that passive leg exercise, they should be started on day 1. Patients should be advised to move. Just keep on flexing and extending the ankle joint so that there is some calf muscle is going on, and passive calf muscles should always be advised to avoid this problem. And these cases should be prophylactically heparinized also. There's one idea of giving heparin in the case of MI also. Systemic embolism, it's a big problem. This typically occurs in LV mural thrombus, and it usually occurs after anterior wall MI. And in such cases, we do echocardiography. If we can pick up the clot, warfarin should be started immediately. Of course, heparin has started. Warfarin should also be started, and that should be continued for next 3 months, even after the discharge of patient also. Mitral regurgitation. This occurs due to papillary muscle dysfunction. and that we tend to produce late pan-systolic murmur. But it's not a you get a systolic murmur, but it's a normally not like a classical MR murmur, slightly late side. Okay, and this is due to papillary muscle dysfunction, and it can lead to acute pulmonary edema. Ventricular septal defect. What happened? This is the heart. Now rupture may occur at interventricular septum. So this will produce ventricular septal defect. This will lead to pan-systolic murmur. In this case, JVP will be raised and it will lead to sudden heart failure. And we can diagnose by echocardiography, and this need is urgent surgical repair is the treatment, because right? Free wall rupture. This is the heart. This is the pericardium. Rupture occur in the myocardium. The whole blood comes to the pericardial cavity. It leads to urgent cardiac tamponade, right? And this, in this case, becomes sudden loss of pulse. Why? This is the heart. It has ruptured. This the aorta is going. As heart is leaking, so there is no forward flow of the blood. There is no forward flow of the blood at all. The patient loses the pulse immediately. BP will be near zero, and patient may lose consciousness because there is no blood going into any part of the body. We can diagnose by echocardiography, and here the patient will come with pulseless, BP-less. It is this condition we like to use intra-aortic balloon pump, which I mentioned earlier. This patient, the only treatment is surgery, and by the time patient is shifted from cardiac care unit to cardiac operation theater, we have to use IABP to maintain the forward flow of blood, otherwise patient will die. So I hope you understood the meaning of where to use intra-aortic balloon pump. So as I talking to you in cardiac tamponade, pulseless electrical activity is there. Pulseless, that means mechanically heart is not beating, but electrical activity is going on. So we call as electromechanical dissociation occurs. And in this case, we get electrical alternance is seen. R wave height varies from beat to beat. Treatment is surgery. Now let me show you the ECG of electrical alternance. You can see R wave height varies. This is electrical alternance. This should not be confused with pulses alternance. Which is seen in severe left ventricular heart failure. Now, late malignant ventricular arrhythmia, they occur 1 to 3 weeks post MI. Hypokaliemia is one of the most important predisposing factor. As I already told you, in any case of arrhythmias, electrolyte imbalance and acid-base disturbance should be ruled out, and that should be corrected. And if once you correct this electrolyte imbalance, the arrhythmias will disappear automatically. However, if there is no hypokalemia, there is no disturbance, then you can go for even 24-hour ECG monitoring before discharge if large MI is there. And if you are getting arrhythmias, ventricular arrhythmias, you have to treat by giving lidocaine, sotalol, or amiodarone. Dressler syndrome, it's a late complication. It occurs after 2 to 3 months post MI. Patient has recurrent pericarditis, pleural effusion, pyrexia, pain, chest. Pericarditis, pleural effusion, pyrexia, pain, chest. And ESR is raised in this condition. Treatment is NSAID, and if not controlled, then we can use steroids also. But by and large, NSAID, they work very well in this patient. Now, left ventricular aneurysm. What is this? In this condition, this is the heart, and MI has occurred, and now a aneurysm comes out. Bulging occurs. Because scar tissue is not formed in this condition, and it has weakened the wall of ventricle and an aneurysm comes out, it becomes a source of clot formation, which can have an embolic phenomenon. So it is usually a late feature. Patient may present with LVF, angina, recurrent VT or systemic embolism. This is one thing which is very dangerous. Mural thrombus is the site of formation. In ECG, what we get? We get persistent ST segment elevation. ST segment elevation, QS wave, that Q wave indicate old infarct, and ST segment elevation, if this keep on persisting, ST segment normally come back to normal within a few days after MI. But after many weeks or months, if ST segment is elevated with Q wave, you should always suspect about LV aneurysm. As you can see in this photograph, the aneurysm is there, and this is due to weakening of the wall of the ventricle. That's why in all case of ACI, in case of MI, we use ACI. ACI has a role to play because it makes the infarct tissue firm. So it prevents the rupture of the wall of ventricle or septum. It also prevents LV aneurysm. Of course, ACI will control the BP and it will also help in congestive heart failure. So there are three reasons why we should use ACI in the case of acute MI. Shoulder hand syndrome is one more complication, is a late complication, again occur 2 to 3 months after MI. Patients start complaining pain in the shoulder joint. This is due to complex regional pain syndrome, intense burning, stiffness, swelling and discoloration because of sympathetic dystrophy, and exaggerated response to traumatic lesion or nerve damage. This is shoulder hand syndrome, late complication. Now, as we prepare the patient for discharge from hospital, now how to do? Detection of a persistent ischemia in an asymptomatic patient. What we do, you do stress tests before we discharge. And it will determine whether angiography is needed or not. If reversible signs of ischemia are there, then do angiography. If there are no changes, then you can discharge the patient without angiography. But if patient is already symptomatic, then do angiography without stress test. That means patient need to do angiography. And what about sexual activity after discharge? This can be done soon after discharge also, but patient is strongly advised not to combine nitrate. If patient must be taking nitrate, then he should not use sildenafil, because this combination will lead, if patient is on nitrate, if he takes sildenafil, it lead to intense hypotension, which can be dangerous for the patient. So a quick recap of the last minute revision point. In the complication of MI, we talked about bradycardia, heart rate below 60, we did various types of heart block. Tachyarrhythmias are more common in anterior wall MI. CLIP classification is to look for the pump failure. Cardiogenic shock, systolic BP below 90, RV infarction, raised JVP with clear lung, low BP, but we give infusion, we give saline despite raised JVP. Pericarditis come with pain chest, deep vein thrombus, which can lead to pulmonary embolism, we use heparin. Systemic embolism can occur, especially from mural thrombus. MR occur due to papillary muscle dysfunction. Malignant arrhythmias we treat by amiodarone, VSD, and free rupture of wall. This leads to weak scar tissue. That's why we use ACI, which make the scar tissue firm. Dressler syndrome, pain, pyrexia, pleuropericarditis, LV aneurysm, persistent of ST elevation with Q wave, mural thrombus, shoulder hand syndrome, which is a late complication of acute MI. Thank you very much for watching this video.